Hello and welcome to Nursing Webinar Series. Myself Shanti, and today's topic for discussion is Pediatric ECMO Fundamentals. For this, I welcome Dr. Sri Charan Garu, who is our consultant Department of Critical Care Medicine and the ECMO expertise from Heart and Lung Transplant Unit from Yashoda Hospital, Secunderabad. I welcome you, sir.
Thank you for the kind words, madam. So today we will be learning about pediatric ECMO essentials, and we will be going on a step-wise basis on understanding the basics of these pediatric ECMO essentials.
Yes. And here I must acknowledge that you always value teamwork and you are always beloved, and we always see you actively engaging and educating the nursing students around. Thank you so much for this. I myself I have attended all of few of your conferences, and it is really value added the concept. Thank you so much. And
Thank you.
yes, as a speaker, I also like to welcome Ms. Jyoti, who is our senior nurse, who is always ready to accept the learning goals. And I welcome you, Jyoti. You
Thank you,
can
ma'am.
share the first slide. Yes.
Thank you, ma'am.
So, sir, the first slide is about as you know, our center is one of the largest quaternary care, and the first insight from your end is, so what is the current knowledge of, this ECMO concept among the critical care nurses?
The concept among critical care, we have to understand that ECMO has been one of the most recent advances which we have actually used. Probably it has been
Yes.
popularized by the recent COVID-19 pandemic. Even though ECMO has been there before, the amount of ECMO usage has significantly increased, probably exponentially after the COVID-19 pandemic. So it is very imperative that the nursing people have to understand the workings of the integrated workings of the ECMO for us to go forward. So
Yes.
the amount of knowledge, it begs that we have to further improve our knowledge on the physiology and the management.
Yes. So going forward, Jyoti, take over and we can start. Yes.
Yeah, what is ECMO? ECMO is extracorporeal membrane oxygenation. A life support provides cardiac or respiratory support. So there are two types of ECMO, VV ECMO and VA ECMO. Venoventricular and veno-arterial ECMOs are there. And VA, both heart and lung, blood is drained from the vein and returned to an artery, and VV supports only the lungs. Blood is drained from the artery, from and returned to a vein.
So, sir, here I would like to ask your concept. Go back to fourth slide. This is little bit, fourth one. This is little bit like VA to VV. Just give us a little simple, your opinion on the same. How one should understand this, about this slide. Yes, if there is any technical issue, you can go back, go to fifth slide, Jyoti. We can ask. Go to sixth. Yes, you can read. We will just do together. Yes.
Why to do ECMO? ECMO is a rescue therapy to support critically ill children with cardiopulmonary dysfunctions like respiratory failures, like ARDS, sometimes poison cases, and cardiogenic issues.
So what kind of cases, it is mentioned here, respiratory failure and cardiac failure. What kind of cases do you get to see? I mean, you were mentioning a lot of, acute respiratory distress cases. And what all cases do you get to see, Jyoti?
ARDS cases, sometimes poisoning cases also, ma'am.
And what will be their ages? Like until date, what age groups have you received?
Less than 10 years we have received till now.
Yes. Very good. And yes, keep going forward. Yes.
The amount of, am I audible?
Yes, you're audible, doctor. Yes.
Yeah. So there is no actually age limitation for any kind of an ECMO patients. So the thing is, we have actually instituted ECMOs in patients who are as less as 4 days old, to patients who are as high as 75 years old. So there is no limitation for the amount of age limit for institution of ECMO.
Yes. And doctor, here I would like to understand what is awake ECMO among children. Like here it is, mentioned also that child can interact with the nurses and do physical sort of exercise, can walk, can eat food, can take feed. Yes, your opinion on the same.
So the amount, awake ECMO actually institutes feeding of sedation and paralysis for patients who are instituted on ECMO. So this concept has been recently popularized because
yes.
This has been recently popularized as it has been the case where patients can actively interact with the nursing staff, and also they can also understand what is actually going on. So
Yes.
awake ECMO can be of various other gradations where people try to be awake on ECMO and try to interact, and it can go to as extreme as people can be extubated. Patients can be extubated on ECMO, and they can be actually speaking, talking, eating, everything while the
Yes.
child is on ECMO support. So it
Yes.
also helps
And I think, yes.
cognitive improvement in cognitive function.
Yes, and it becomes very easy for us also to understand what is specific need of the children. Yes,
Exactly. Yes.
yeah. And so again here I would like to ask you, or maybe Jyoti also, try to understand, is pediatric ECMO different from adult ECMO, Jyoti? Your insight or your
Yes,
knowledge on
ma'am.
the same?
Definitely, pediatric ECMO is significantly different from the adult ECMO. Some
Yeah.
core values are same, but technical setup and management due to age-specific factors, it will be varying.
So here Dr. Sri Charan will tell whether you're right or wrong. Yes, Doctor, which she
The age
stated
specific
correctly.
factors, they're actually helpful now. The age specific factors are definitely there. So the thing is, one of the primary changes where we can actually see the differences between adult and the pediatric ECMOs. First, obviously, are the sizes of the cannula. The cannula
Yes,
sizes are much smaller in pediatric patients, and the site of cannulation. So before the
yes,
baby is actually ready to walk, the
yes,
femoral venous or the inferior vena cava is not as much developed. It is much more small. It is smaller than that of the superior vena cava in pediatric age group. So
yes.
we will be trying to cannulate the superior vena cava more for drainage purposes in pediatric ECMO as opposed to adults where we use inferior vena cava. And
So here,
where as and
yeah, please go on.
yes. The third one is that because the amount of flow rates that we will be running on pediatric ECMOs is much lesser than the adult ECMOs, the amount of anticoagulation requirements and the chances of circuit clotting and everything has to be taken into consideration.
Yes, yes. And I would like to ask one thing, like among newborn or till the 1 year of age, what kind of condition do we, should we consider for ECMO, doctor?
It is the conditions remain fairly the same, and most of the times in the newborn population, it is if it is
Yes,
uh, uh, meconium aspiration syndrome or any
yes,
ARDS of any etiology, myocarditis, myocardial dysfunction, persistent pulmonary
yes,
hypertension in the newborn, and community acquired pneumonias as respiratory
yes,
as well as cardiac causes can be considered. But
yes.
mostly in the neonatal populations, the instead of venous ECMO, the
VA,
choice of ECMO for both respiratory as well as cardiac causes would be veno-arterial.
we know it. Yes, thank you. And yes, Jyoti, take over. Yeah,
Pre-ECMO follow-up for less than 10 years of age. Here mostly will follow up regarding the concerns has to be taken by the guardian, and medications we have to keep ready like sedations or inotropes, whatever is planned is there, and monitoring the vital signs if baby is hemodynamically stable or not.
I think, and the success of the, ECMO procedure depends on the, not success, I mean the proper coordination and planning has to be done before the, procedure is been planned. Yes.
Yes, yes.
Yes.
Yeah. And
How
I
ECMO
think
works.
here we would like to have your opinion. I think, very simultaneously we will run the slide as well. How ECMO works in simple, term for the audiences who are viewing this live. Yes.
So, ECMO actually institutes one of the three major things. One is that we are draining the blood from the venous system. This drainage of blood from the venous system is done with the help of a centrifugal pump. Okay.
Yeah,
After the
centrifugal pump.
with the
Yes.
help of the centrifugal pump, it is actually after this blood is drained, it is sent through an oxygenator or a
Yes.
membrane, as we call it. So that's called a membrane oxygenator.
Okay.
That's why the name extracorporeal membrane oxygenation. So after
Yes.
it's sent through a membrane oxygenator, the blood is oxygenated in the membrane oxygenator, and the oxygenated blood, and it is also decarboxylated simultaneously. And the oxygenated blood is again pushed back into the patient. So if it is
Yes.
returned into the venous system of the patient, it's called the venous ECMO. If it is returned into
Yes.
the arterial system of the patient, it is called the veno-arterial. It also
Yes.
constitutes the equipment, the consoles, the thermostat, externally placed thermostat, the consoles as well as the blender. What you are seeing on the monitor is right now is the
Yes.
console which is showing a 4.3 liters of flow. This is obviously
Yes.
an adult
Yes. This
ECMO
is a
patient,
concern.
which
Yes.
tells us which tells us how much blood is actually flowing. And next is the
Yes.
thermostatic control, where because we are
Yes.
draining a lot of blood from the patient and it is being subjected to oxygenation, the membrane oxygenator, we can actually expect a drop in the temperature. So a thermostat is used to maintain the temperature of the blood,
Yeah.
which is drained from the patient. Then
And
after
it
it is
is,
actually,
yeah, yeah.
yeah. Then the other thing is the blender, which actually helps us in the amount of oxygen which we are giving. So as in the ventilator, if it's called a fraction of inspired oxygen, on a blender it is called a fraction of delivered oxygen. We can actually call that as an FDO2. So we can
Yes.
control two things with the help of a blender. One is the FDO2, and second is what is known as the sweep gas. The sweep gas flow, as you can see the flow meter on the blender,
Yes.
the sweep gas
Yes.
flow is
Yes.
what determines the decarboxylation, how much carbon dioxide can be removed. Ideally, in a ECMO patient, we generally put a blender. I mean, sweep gas is to blood flow rates in the ratio of 1:1.
Yes. Yes. Yeah. So going forward, Jyoti, yes, and yeah.
Weaning criteria and monitoring. Ventilation and oxygen. The child should be able to maintain adequate ventilation, PaO2 more than 60 mmHg, and PaCO2 less than 50 mmHg on FiO2 less than or equal to 0.4 and sweep gas less than 1 to 2 liters per minute. Hemodynamical status, cardiac output, child native cardiac output and urine output should be sufficient to meet the metabolic demands.
I think this is the already the existing protocol which you all
Yes.
have educated your nurses, and yes, so these are the right winning criteria. Yes. Yeah, going forward.
Nursing care and coordination. So in nursing care, mostly we need to focus on the bleeding and clotting factors. We have to see the ACT and APTT, watch for bleeding or clotting signs, IV fluid and nutrition, which is very important, IV charting and TPN or feeds if advised. And infection control practices, we need to be maintained very strictly to maintain the infection, to prevent the infection. And to also, we need to change the position to prevent the bed sores.
Yes. So, doctor, any other challenges you witness or anything you would wish to convey here in this forum of live webinar, apart from
So
all the
so I would actually divide the monitoring or whatever the nursing care that is being given into a
yes,
patient-related monitoring as well as a circuit-related monitoring. So that is actually helps us in understanding whatever we are looking at here. So
yes,
everything actually is covered. So circuit-related monitoring also is to look for any clots, look for the flashlight test to look if the
yes,
oxygenator is functioning properly or not, to see the color difference, inking of the
yes,
tubes, chattering. So these kind of
yes.
device-specific monitoring has to be done regularly on a patient.
Yes, yes. We are just close to the end of the discussion. I think, yes, as you have mentioned, bleeding, infection, or chattering, and blood clot formation in the oxygenator. Share the next slide, Jyoti. And yes, as you also said, the color change. Yeah, color
Yes.
change also. And what the nurses should do if they witness all these kind of machine related or sometimes pediatric the patient related any problem happens. Should they escalate or should they what initiate intervention they should take?
So it actually depends upon understanding the cause of whatever
Yes,
the trouble we are in, essentially speaking. So if
yes,
the patient is having hypoxemia, it always starts from the patient end to the machine end or from the machine end to the patient end. So we
yes,
have to look for
yes,
it. Color changes, as I was actually mentioning, a color change. Uh, if both are dark, it's a problem. If both are bright, it's another problem. But it is a
yes,
problem, all right. So there
yes,
should be a definitive color change if you are looking at the return canal versus the drainage canal. So if
yes,
you can actually see in the right sided picture that it is both are dark in the sense that there might
yes,
be an oxygenation, oxygen disconnection from the oxygenator or something of that sort which are happening. So
yes,
there are
yes,
certain aspects in the troubleshooting where a simple step is just going to save the life. So in here,
yes,
we have to understand what are those steps. So understanding the
yes,
causes are the troubleshooting with hypoxia, hypercarbia, etc. are supposed to be done, and it comes with practice. So the more cases you see, you'll be able to understand what might be the problem in this.
And so, are the nurses able to identify and escalate to you at any time when you are on your routes and
Yes,
you get a call?
there is definitely. Yes,
Yes.
we can actually understand. So
Yeah.
it comes from identifying or formulating pathways to
Yes.
identify a cause, and to actually go from one cause to another cause and ruling out the most probable causes.
Yes. Yes.
So, for
Nice.
example, if the patient is having hypoxemia,
Yeah.
the example is the flowchart for if the patient is having hypoxia, your trend of saturations is very much important in this monitoring. So if the patient
Yes.
saturations are above 94% till last 5 to 10 minutes, and then now they are suddenly 78 to 79%. And the first thing what you have to look for is that how, like, what are the flows
Yes.
adequately maintained as much as before. So most of the times what happens is that if the circuit starts to chatter, the flow starts to come down and the patient might be hypoxic. So look at
Yes.
the flows, look at the color difference. If at all there is no color difference and both of them are dark, look at the connections between the oxygenator to the central oxygen console. And then if there is adequate color difference, now come back to the patient. Whether the patient is agitated, febrile, all these causes have to be ruled out to identify what is the cause of hypoxemia. So identifying these pathways and managing patients according to these pathways is going to help us in identifying the problems earlier.
Yes. So conclusion note again, as you have said, identification and escalation is very important. And thank you for your valuable time. I have seen your, last week webinar as well, and attended your ECMO conferences as well. And we urge all the participants and viewers to just log in www.Yashoda Hospital website so that you get more health talks, as sir is expert in this, and we get to learn more. Yes, and thank you. We end the session. Thank you for your valuable time. And thank you, Jyoti.
Thank you.
Thank you,
Thank you
ma'am.
for this
Thank
opportunity.
you.